Okay, wow. Welcome. So I've been doing this for a few years now, but unfortunately COVID hit right around the time I took over this program. So it's been all virtual. So it's nice to be back here in this room again and seeing everybody in person and rather than just the black screen that I have seen for the last couple of years. So this is nice. I'm Dr. Dillon, Sukhjit Dillon. I am an emergency medicine physician here downtown at CRMC. I went to Fresno State, then Chicago Medical School, and then back here for my residency and stayed on. So it's been a great journey, and I'm glad that I'm here. MiniMed is to introduce you guys to various different topics that are important for your health, your and your loved one's health. So to learn a little, have fun, ask lots of questions. We have great speakers lined up. So I hope you'll have fun over the next 4 weeks. To get this started, we have Dr. Roytman. She's an awesome teacher. You'll see her soon. You'll listen to her soon, so you'll know. She is our liver specialist here at UCSF Fresno at CRMC. Maybe one of the only hepatologists we have here in town. So if you have a liver disease, you get to see her. So I hope you don't get there, but she's awesome. She will talk today about fatty liver disease, something that has become pretty more prevalent, it seems like, and she'll mention that for sure. And I want to learn more about it too, to see how I can prevent it and potentially the treatment that we need for it. Dr. Roytman did her medical school at Oregon State University, and then did her internal medicine residency at Mount Sinai, and then joined us. And how long have you been here now?
This is my 7th year.
Oh my goodness, so long time. And she'll tell you a little bit more about her journey when she gets up here, or if you want to talk from there, that's totally fine. I think that might be better.
I'll get up.
Okay, awesome. Okay, perfect. She did break her foot and she still showed up. So props to her. That's how dedicated she is to teaching. So I don't think I would have done that. So thank you. I really appreciate that.
Thank you so much.
Yes. Welcome, Dr. Roytman.
Thanks, guys. So I have to tell you how I broke my foot. So yesterday, I was working on my slides. It happened yesterday. So I was working on my slides for this talk. And, I was really in the zone, like, it's so cool. I really love this topic, la, la, la. And I was sitting on my foot, just because that's how I normally sit. And I got so involved in working on the slides that my foot fell asleep. And then I got up and my foot wasn't awake, so it twisted under me. So that's what happened. But very embarrassing. I do a number of, fairly dangerous things like skiing, black diamonds, and hiking and rock climbing, and I've never broken anything. And here I broke my foot in my own office. So that's really embarrassing. But anyway, so a little bit about me and my journey into medicine. So I was born in a country that no longer exists. It's called former Soviet Union. And my family is Jewish. And in the former Soviet Union, that wasn't a particularly popular thing to be. There was a lot of restrictions. One of them was a restriction on how many Jewish kids could go to medical school. And the magic number was 5% of the medical school class. Well, I wasn't going to be that magic 5% because there's probably a lot more people that are smarter than me. So I decided this wasn't going to be a path for me. So when I moved here, I was done with high school. I was 17. We finished high school a little earlier back in the old country. And what I realized is in the United States, if you work hard, and you do all the right things, you can actually do whatever your passion is. And certainly my passion has always been in medicine. And I thought I would give it a go. So I started by working as a nurse's aide in a state nursing home, learn how to bathe patients, change diapers, feed patients, make beds. So that was to this day, I say, is the greatest experience I could have had, because it really taught me how important it is, the work of our nurses' aides, our nurses, and everybody who takes care of our patients. As physicians, we spend sometimes 10, 15 minutes in the patient's room in the hospital, and it's the nurses' aides and the nurses who are there, really doing the hard work. So I worked as a nurse's aide for a while, realized that this is probably not a sustainable career for me. Patients are really challenging to lift and change, and I thought this is probably not something I can do for the rest of my life. So I eventually decided to go to school, started in a community college. Didn't realize that in order to go to like a regular college, you either have to graduate from an American high school, or you have to pass an English as a second language test. Didn't know that. So ended up in a community college for a while, eventually did pass the test as English as a second language, and went to University of Hawaii. Really, it was a great experience. Worked in a research lab there, took care of a bunch of rats, and was part of the discovery of some of the earlier antidepressants, purely just by taking care of the rats. I was not involved in the academic side of it. And so eventually did finish college, went to Oregon Health Sciences for medical school, and did my internal medicine training at Mount Sinai in New York. Really fun experience, loved New York, did not love how crowded it was. So eventually moved back to Hawaii. This is where my family settled, and worked with my mentor, Dr. Naoki Tsai, who taught me all I know about liver disease or hepatology. Also did a medical education fellowship. I really always loved teaching. And long story short, this is how I ended up here, teaching all of you. So today we're going to learn about fatty liver disease. And there's lots and lots of things to learn about fatty liver disease. One of the first things is that it now has a new name. And we'll talk a little bit about, what was the reason for the disease getting a new name. Yeah. Do I turn it on? Sorry. Is there an on button somewhere?
I can maybe help you with these.
No, are we stuck? I'm sorry.
Yeah.
Okay.
It worked when I showed you.
Oh,
It's there.
yeah. Okay.
Maybe not pushing hard enough.
Okay.
Oh,
I'll try hard.
Yeah, just give it a positive.
Okay. Okay. All right. Moving on. Take two. So, fatty liver disease. So, this is an old name, but we'll stick with an old name because I think it's probably easier to understand at this point. So, fatty liver disease basically means an accumulation of the fat in the liver. And NAFLD, or non-alcoholic fatty liver disease, is like an umbrella term. And then from there on, there's two things that are under that umbrella. One is non-alcoholic fatty liver, and that means you have a bunch of fat stored in your liver, but it isn't doing any harm. On the other hand, we have something called NASH, or non-alcoholic steatohepatitis. And that's a little bit of a mouthful, but what that means is because you have fat in the liver is inflamed, and this inflammation causes over time scarring or fibrosis of the liver and can lead to advanced liver damage such as cirrhosis. So this is a key thing that I would love for you guys to walk away from this room, that liver disease can be caused by a number of different things. It's not just the alcohol, because a lot of patients, when they first come to my office, they're very sad. And they're like, Dr. Roytman, I don't understand. I have never drank in my entire life. How could I have cirrhosis? Well, fatty liver disease is one of the ways those patients can have cirrhosis. So I start by really reassuring them that I know you're not a drinker. I know you're telling the truth. And there's unfortunately many other ways to get there. So we've certainly seen an increase in fatty liver disease over the last decade or two. So why is that? What is happening? So we're going to look here, and we're going to travel back to 1994. That's a really long time ago, probably before many of you were born. And you can see that obesity was not super prevalent in the United States. So anywhere between 14 and maybe 18% of patients met the definition of obesity. Now we go back to 2000, and you can see that the map is getting a lot more red, so more patients are getting obese. And now we're in 2015, and now the entire map is red. So look at the number here. So dark red is greater or equal to 26% of patients meet the definition of obesity. Diabetes follows a very similar pattern. Not that many people in the early 90s, more so in 2000s. And again, really greater than 9% of patients have diabetes in early 2015. So again, let's remember the number, about 26%. This is the dark red areas. So now we are going to travel to 2020, to the year 2020, right? And you can see that the map looks very red, right? So in the beginning, you kind of think, well, things haven't really changed that dramatically. But then when we look at the legend here, you can see that the green areas is that you're 25 to 30%. So we are starting where we left off at the earlier map. So things have progressed dramatically. And the darker red is your 30 to 35% of patient population. And even the darkest red is greater than 40% of patients are considered obese. That's a whole lot of patients. So when we look at a non-Hispanic white patient populations, things don't look so terrible, right? Especially over on our side of the world, in the West, things don't look too bad. So that potentially is reassuring. However, if we look at a different patient population, non-Hispanic African-American patients, the entire country looks anywhere from 35 to over 40% of obesity. And that's pretty startling. When we look at the patient population that is very relevant to us is the Hispanic population. You can see, again, so maybe not as dramatic as the obesity rates in the African-American population, but certainly very, very dramatic. So obesity and fatty liver disease and diabetes go hand in hand. So this is probably the simplest explanation for why we're seeing just an explosion of fatty liver disease in our country and across the world. So who is at risk for fatty liver disease? So we have a concept of something called a metabolic syndrome. A metabolic syndrome consists of having diabetes or elevated blood sugar, high blood pressure, high cholesterol, as well as something called central obesity. So when people gain weight, a lot of them, or sometimes they tend to gain the weight around their midsection. And this is called central obesity. And that specific pattern of obesity is associated with the metabolic syndrome. This causes heart attacks. This causes fatty liver. This causes a whole bunch of metabolic diseases. So diabetes, certainly, high blood pressure we talked about, high cholesterol, and this is a picture of central obesity. And really, we realize more and more that it's really the diabetes that is a #1 culprit in fatty liver disease. So as I alluded earlier, fatty liver disease has gotten a new name. So why would we suddenly change the disease's name, right? There's got to be a good reason for it. And really, the reason we wanted to change the name for fatty liver disease is to decrease the stigma associated with it. And I'll walk us through this. So first of all, so the name for fatty liver disease, or the scientific name for it, is NAFLD. So non-alcoholic fatty liver disease. And we'll go letter by letter. So the first letter is N. So the N is non, which is really not a great term. It may mean not important, not well understood, not interesting. So not a great letter word to start the name with. So not really all that great. So then A stands for alcohol, but this is a non-alcoholic fatty liver disease. So it's really not fair to put the alcohol in the name of the disease if the alcohol was never really there. And it can be really stigmatizing, especially in the societies where alcohol is forbidden. Next, we have F. So F stands for fatty or fat. And this is really stigmatizing. And we certainly learned a lot about body positivity and avoiding fat shaming. So again, really not an ideal letter to have in the disease name where we're trying to decrease the stigma. L stands for liver. We seem to be okay with that. And D stands for disease. Well, is everybody who has a fatty liver have a disease? I think this is a kind of an unanswered question at this point, so it may or may not be true. So I think we agree that maybe NAFLD is not a great name for a disease. So what are the downsides of changing the name? Well, there's lots of downsides. First of all, it's an implication for existing body of literature. If you're going to go to your computer and search for NAFLD, lots and lots of stuff is going to pop up. Well, if we change the name, how are we going to deal with this? So there are ways to do it, but that certainly is a consideration. Next is implications for research and funding. There's lots and lots of research that is happening in fatty liver disease, but funding is necessary, and you do need to know how to ask for funding. So that's another consideration. Patients may be confused. So if you've been seeing a hepatologist or your regular doctor for years and years, and they've told you you have fatty liver disease, and now suddenly you have a different disease, this is going to potentially create some confusion. And last but not least is that there's difficulties in finding a new name. So really, like, how hard could it be? I think we can find a new name. Well, it actually turns out it was really, really, really hard. So let's give it a try. So one of the contenders was MAFLD, right? So instead of non-alcoholic, we substituted for M, metabolic. So metabolic liver disease, it can be viewed as a manifestation of a metabolic syndrome. Well, that makes sense in the adult world. In a pediatric world, it does not make sense because children sometimes are born with metabolic disorders or genetic disorders. So in the world of pediatrics, metabolic liver disease means something very, very different. So the pediatricians were not happy about that. So since we're talking about pediatrics, I want to point out a really great book written by a pediatrician named called Junior Has Fatty Liver. So in addition to the adults, becoming more obese and developing metabolic syndrome, that has also been true for children. So this happens in children, and if there's anybody in your lives that you may be worried of them about developing fatty liver disease, that's a great children's book for it. Next is A. A is associated. What's a really vague word? Really not a great way to name a new disease. F, we're still stuck with fat and fat shaming, not ideal. L, we're still okay there. And D, we're still really not sure if everybody's sick, or maybe more people are sick than we're realizing. So let's give it another try. Okay, metabolic liver steatosis, also known as MLS. Well, some of the soccer fans might not be happy about this. For those of you who are not soccer fans, it's Major League Soccer. Next one was steatosis, obesity-associated liver disease, abbreviated as SOLD. Well, sold out, really not a great name either. Insulin-related steatosis, IRS. Well, it was no takers for that one either. So I actually didn't make it up. I mean, there was an international body of people that has been working on renaming the disease for several years. So these are all real. Anyway, next one is insulin-resistant associated liver steatosis, or IRLS. Let's just give up already. So anyway, so we're still stuck with the disease formerly known as NAFLD. And maybe really the key here is to realize that this is not a single disease, right? Maybe we have steatotic liver disease. Maybe this is our metabolic folks. Maybe this is the patients who are misusing alcohol, because that ends up in a fatty liver as well. This is our pediatric population with genetic disorders, and this is the combination. So maybe this is the way to do it. And this is the way it was done. But generally, when you have many organizations, many physicians work together on something relatively simple, they make it very complicated, which is exactly what happened here. So the NAFLD got renamed. It's called steatotic liver disease, or SLD. And that's okay. Now, over here, we have metabolic dysfunction associated steatotic liver disease, also known as MASLD. Well, that's a little bit of a mouthful. We've also kind of agreed that we're just going to ignore the fact that there's a D in there and just say it's MASLD. Okay. Anyway, moving on. It's already changed, so I think we're sticking with it. This part I actually really like. So this is called MET-ALD. And basically what it talks about, that some patients, their disease is predominantly because they're overweight, they have diabetes, they have a metabolic syndrome, but some patients also overconsume alcohol. So there's a spectrum, right? And this MET-ALD allows us to account of a little bit of drinking, primarily a fatty liver disease from a metabolic syndrome, or a fair amount of drinking, so primarily more in the alcohol misuse spectrum. Then we have purely alcohol-associated liver disease. Then we have some of more unique situations such as drug-induced liver injury, genetic disorders, and there's a small area for the folks we just can't figure out why they have fatty liver disease. So this is a new, fresh off the press nomenclature. So, but really is the name change is more of a distraction, and we really just need to get to the real issues. And the real issues in my mind is figuring out who is at risk for fatty liver disease. How should we identify patients at the highest risk? How do we incorporate screening of those patients into our practice, into practice of primary care providers? What are the treatment targets? And is there any medication available at this time? So to me, this is really the real issues that we can address today. So there's a few things that got changed along with the name change. And ASLD, which is American Association for Study of Liver Diseases, which is a parent organization for all liver physicians in the country, came up with a guideline. So in addition to the name change, they actually did some really useful things. And a few things that they pointed out is that the liver labs can be frequently normal in patients with steatotic liver disease. Basically, if you go to the doctor and your doctor checks your blood test, your liver test may be normal, but it doesn't mean that you for sure don't have liver disease, because sometimes if you had fatty liver disease for many, many years, the liver has developed scarring. So there's so much scarring, the liver can no longer produce those elevated liver tests, and that may be very misleading. So our organization specifically tells you, hey, look out for your patients. It's not just about the liver blood test. Also, it says that the liver blood test, specifically one of the values is called ALT, or liver test. The 30 is, anything above 30 is abnormal. And if you're fun and games, at some point you're looking at your own lab test, look and see what the lab is telling you is the normal. And oftentimes the lab value would be like 40 or 50 or sometimes 60. This is not the normal values. So sometimes when we look at it, everything is in the green. So this is great, but it's actually not the right number. Ultrasound, so this is a way to take a picture of your liver, sometimes is used to look for patients with with fatty liver disease. But when the ultrasound looks at the liver may look abnormal, but it may look abnormal because there's fat in it, there's scarring or fibrosis, or there's inflammation. So again, not really a great strategy. So we've all known this for some time, but it's really great that the organization has put it together and made this statements. So the next statement that our organization made is general population-based screening for fatty liver disease is not advised. Well, a lot of us were really disappointed because if in some populations, greater than 40% of patients are obese, greater than 40% of patients are at risk for steatotic liver disease. So I would say certainly we should go ahead and screen pretty much everyone, instead of really being selective about it. But that's not what ultimately the recommendations were. What it did say that patients who are at high risk for development of liver disease certainly should be screened. And those patients include patients with diabetes. Again, the diabetes comes up again. Something called medically complicated obesity. This means that the patients are not only heavier than they should be, but they have one obesity-associated condition, such as diabetes or high cholesterol or high blood pressure or obstructive sleep apnea, family history of cirrhosis. So why is family history important? So what we've learned over the last couple of decades, that not everybody is at the same risk for developing fatty liver disease. There are certain populations, specifically Asian populations and Hispanic populations, whose genes are made a little differently. The fancy word for that is a genetic polymorphism. So people with certain genetic polymorphism are at a higher risk of developing fatty liver disease, even though they may not be as heavy or not have as many components of a metabolic syndrome as a Caucasian patient might be. So again, very relevant, to us practicing here in the Central Valley. So this is very important, but that's why we're paying attention to the family history. It's an indirect way of making us think, hey, you have a lot of liver disease in the family. Maybe you are, part of the genetic polymorphism. And certainly combining fatty liver with alcohol misuse, this is another risk factor. So what actually happens with the liver when there's excess fat? So when we look over here, so this is a liver biopsy. When we do liver biopsies, we take a small needle, we take a piece of the liver, we slice and dice it, and then we look at it in the lab in the microscope. So this is a piece of the such piece of the liver. So you can see most of the liver is pink. This is a normal healthy liver tissue. The little white dots is literally fat globules. So the fat globules should not be present in a healthy liver. On this slide over here, there's something called ballooning. And you can see some of the liver cells look kind of unhappy. They look bloated. This is called ballooning, and this is one of the manifestations of fatty liver disease. Next, we have something called lobular inflammation. And you can see there's a bunch of blue dots. Blue dots are in the inflammatory cells. When something isn't going right in your body, the immune system is going to send out the inflammatory cells to see if it can clean it up. And here we have a lot more of the blue dots or much more significant inflammation. So this is what happens in terms of the steatosis. Over here, we're starting to see the development of scarring. Scarring and fibrosis are the same thing. Fibrosis is just a fancy way of saying scarring. So here you see mostly pink liver or red liver, a bunch of white dots, and you're starting to see some of the blue lines. And the blue lines are the scarring. And you can see there's more scarring and there's more scarring. And over here, the scarring bands are now connecting. So when the scarring bands are connecting, you have developed cirrhosis. So what is important is, do we worry about how much fat globules in the liver? Do we worry how many inflammatory cells are in the liver? Or do we worry how much scarring is in the liver? And it turns out that it's the scarring that we're most concerned about, because it's the scarring that ultimately leads the disease progression to cirrhosis and potentially to liver cancer. So what we see on this graph over here is that we've looked at patients with either no liver disease or patients with early fibrosis. So F0 to F2 means early fibrosis. And you can see that if you have early fibrosis or no liver disease, you're going to live a long time. However, if you're looking at this line over here, and these are the patients that have more scarring or more advanced fibrosis, you can see that their mortality or their chances of dying increase significantly. So how do we figure out who has scarring? Like, how do we estimate the amount of scarring and figuring out which patients do we really need to worry about the most? So there's a number of different ways to do it. There's a simple way that we take the patient's age, and then we take a number of blood tests, liver tests, as well as platelet count, and we plug it into the iPhone and the formula, and it spits out a certain number. If the certain number is high, we're like, wow, I think this patient really has more liver scarring. I really should jump on managing their diabetes, get them to lose weight, whatnot. So it's not a perfect way of doing it. There's a number of reasons why the platelets or even some of the liver tests can be abnormal that is not necessarily related to the liver scarring. So it's a good screening test, but we really have to think, does it make sense? So what are the other ways of figuring it out? So we have a technology called vibration control transient elastography. I know it's kind of a mouthful. So the brand name for this machine is FibroScan. And I'm going to apologize for using the brand name because otherwise it's just too much of a mouthful to say vibration control transient elastography over and over again. So anyway, so this is the FibroScan. The FibroScan is a probe that is attached to a computer. And this probe, I know it looks really large, but it actually fits into the palm of my hand. So what this probe does, it sends a shear wave, or you can think of it as a sound wave, through the liver. The sound wave goes through the liver and it bounces back. And then the probe can measure the speed of the sound wave travel. So that's great. Well, how does it help us to understand how much scarring is in there? So if we think of the liver as a rubber ball, and then a healthy liver would be a nice, soft, squishy rubber ball. So when we send the sound wave through the rubber ball, if it's kind of soft and squishy, the sound wave is going to take its time going through the soft and squishy rubber ball. So the slow speed of sound wave travel means a nice, healthy, squishy liver. On the other hand, if our liver is scarred up, and you can think of it as kind of a rock hard cirrhotic liver, the sound wave is going to travel a lot quicker through something that is rock hard or close to rock hard. So the speed of the sound wave travel will equate to the cirrhotic liver or liver with a lot of scarring. So that's one of the things that FibroScan can do for you. What else can it do? It can also tell us how much fat is in the liver. So we're back to the rubber ball analogy. So if your liver is healthy, it does not have a lot of fat deposits, the sound wave is going to travel through the liver and it's not going to bump into any of the deposits. So it's going to stay, a sound wave for a good long time. However, if your liver is full of fatty deposits, the sound wave is going to bump into a bunch of those fatty deposits and it's going to grow smaller or attenuate. So degree of attenuation tells us how much fat potentially is in the patient's liver. So this is a very easy test. It's non-invasive and can be done in 15 minutes in the doctor's office by trained technicians. And then it tells us how much scarring and how much fat is in the liver. So in this patient, for example, the report tells us that they have very little scarring, F0 to 1, yay, that's great, but they do have a lot of fat. So S3 corresponds to greater than 66% of liver cells are full of fat. And I find that when I show the results to the patient, it's really something tangible that they can hold on to. They can understand, wow, this is really great. My liver is pretty healthy. I have not gotten into trouble with liver scarring, but I have a lot of fat. And if I don't get rid of the fat in the liver, then it's going to produce scarring. So I find that it's a great educational tool for patients. This is another blood test. It's called an ELF. This is something that may be up and coming, and this is another way of estimating how much scarring is in the liver. I don't use it routinely. I think it's kind of expensive, and I don't really want the patients to pay for it at this point. May change, but so anyway, so this is the diagram that our Liver Society came up with, and basically what the diagram tries to do is it tries to give us guidance on how to identify patients that really need our attention sooner. So remember the blood test, the simple blood test that I show you, it's called FIB4. If the FIB4 number is greater than 1.3, is not greater than 1.3, then you're in the green. You're good to go. This is a patient that probably doesn't have advanced scarring. So we can just continue watching them and managing their risk factors and counseling about a weight loss. However, on the flip side, if that number is greater than or equal to 1.3, then we are going to do the second level of assessment. This is your FibroScan, and this is the fancy expensive blood test. You can do either or. I do the FibroScan because it's a lot more accessible for the patients. So then, if you found out that on your secondary assessment, your patient is okay, right? They do not have advanced scarring on FibroScan, then you can return into your green zone up top and just continue monitoring them. However, if your patient is in the high risk category by secondary assessment, this is the time to refer your patient to a liver specialist. So more aggressive treatments can be done. One more caveat to this, if your FIB4 is really high or your liver tests are persistently elevated, then they should be directly referred to the liver specialist. So that's a fairly simple diagram, and I think it would help us identify patients at the highest risk for disease progression. So, okay, we've talked about this. So now that we've identified patients at high risk for fatty liver disease, what do we do about it? Well, the handle on your recliner does not qualify as an exercise machine. So really, one of the most effective ways to improve your liver and prevent progression of disease is weight loss through exercise. And I find that a lot of times when my patients start exercising, even before they lose a significant amount of weight, their liver test already improved. So I think there's something special and unique, that has to do with benefit of cardiovascular exercise that goes beyond just a simple weight loss. Oops. So this is a little bit of a complicated slide, but it basically tells us that losing weight leads to the reduction of scarring. So back about 15, 20 years ago, we thought that once your liver has developed scarring, you were done. So this was scar tissue, it could not be improved. Now we're realizing with curing patients from hepatitis C, treating patients for hepatitis B, that this scarring can be reversible. And certainly there's a threshold at which point the scarring is reversible. And I want to bring your attention to this 10%. So 10% total body weight loss. So if your patient comes to see you and they weigh 200 pounds, 10% of total body weight loss would be 20 pounds. It seems doable, right? I'm not asking the patients to lose 40, 50, 60 pounds, but 20 pounds for most patients, they're like, okay, I think I can do this. When the patients lose 10% of their total body weight, the inflammation of the liver resolves in 90% of them. I mean, that's amazing. 81% of them show some regression of the liver scarring. This is, again, remarkable. Steatosis improves in all of them, fat in the liver. The trouble is that only 10% achieve the 10% total body weight. So this is really challenging. So what else can we do for the patients? We can talk about bariatric surgery or weight loss surgery. And, the bottom line is weight loss surgery works. So what this graph shows that here in the before area, many of our patients had a lot of fibrosis. After the surgery, you can see that the fibrosis regressed in a good amount of patients. More patients are now in this white minimal fibrosis zone compared to where they were here. So bariatric surgery works great. It is a surgical procedure. It is a life-changing surgery, which certainly would help you with weight and obesity, with weight and fatty liver disease and risk for heart attacks and diabetes, but it's not problem-free. You may develop vitamin deficiencies. It's a lifelong project. So certainly not something that I encourage all my patients to jump to as a first thing. So this is a really nice picture of what happens when patients have bariatric surgery. So this is our picture before surgery. You remember those white circles, meaning lots of fat. You remember the blue strands indicating the scarring. And this is after surgery. You can see that we have a lot less white circles and the fibrosis or the scarring has resolved very nicely. So it works very nicely. So what else can we do? So how many of you heard of the new weight loss drugs? Show of hands, lots of people, right? So this is one of the weight loss drugs called semaglutide. This is a generic name for it. In the weight loss world, it's known as Wegovy, and in the diabetes world, it's known as Ozempic. So this was a study that was published in New England Journal of Medicine, and this is like the cat's meow of medical journals. This is the best journal ever. So anyway, and this study showed that when we give people semaglutide, Wegovy, or Ozempic, the steatosis or the inflammatory component of the liver resolves very nicely. but not so much with the fibrosis. The fibrosis did not resolve as nicely. So everybody kind of scratched their heads, like, why is it? Like, it's such a magical drug. Why didn't the fibrosis improve? And I think the reason for why fibrosis did not improve is that the study period was too short. It was only 18 months long. And I think, it takes a long time to develop liver scarring. It takes a long time to undevelop liver scarring. So I think there are longer clinical trials with more patients that are currently underway with this compound and similar compounds to it. So I think, in my opinion, and many of the liver specialist opinion, this is probably ultimately going to be the next drug for fatty liver disease. But this is an injectable drug. This is really, maybe you don't want to be committed to it for, the rest of your life. So what we're hoping would happen is the use of these drugs would allow patients to get a jump start in their weight loss journey, to show them they can be successful, to show them they can manage their weight, they can start exercising, they can learn to eat healthier. And over time, they do not need to be on a drug, because this is not something that we really want to commit patients for the next 30, 40 years. But I think this is probably where we're going. Everyone knows food is bad for you, but I don't know what else to eat. So certainly, joking aside, there are things that are good for the liver. And again, I want to emphasize that this is an adjunct, right? This is in addition to exercise and weight loss and potentially weight loss medications that some of our patients may need. But there's a couple things. One is coffee. Coffee is actually great for the liver. Coffee, when consumed black without cream or sugar or any other fancy stuff that the Starbucks puts into it, it improves the gut health. It encourages our gut to grow healthier bacteria. And when there's healthier bacteria in our gut, it decreases inflammation in the liver. And it's inflammation in the liver that eventually causes progression of scarring. Similarly to yogurt. Yogurt, and I think you know what I'm going to say, plain yogurt, not the yogurt that, has all kinds of yummy, delicious sweet things, because that would be called eating dessert. But eating plain yogurt, you may add a little fruit to it, but, you're in control of it. It also populates our gut with healthier bacteria, and that also is good for the liver health. When you hear healthy bacteria, a lot of our patients hear probiotics, which is true. But sometimes they also hear, go to the store and buy probiotics in the pills, which is not true. Dietary supplements in the United States are not FDA regulated. They may not contain what the label says. And in the worst case scenario, they may contain something harmful to your health. So I really discourage the use of dietary supplements in our patients, including the probiotics. So what have we learned? Fatty liver disease has a new name. Do I love it? No, but it's probably a pretty good attempt on destigmatizing the previous name. So I think we're going to roll with it. We have new guidelines in addition to the new names, and certainly the guidelines define populations at risk. They recommend screening for advanced fibrosis or scarring in the liver in those high-risk populations. And they provide us with a nice algorithm that we can, probably plug into our phones and help us identify those patients at high risk. Overall, I think we're in the very beginning of our journey with steatotic liver disease, and there's lots and lots to study and learn. And that's how you handle liver. And the last thing I want to share with you is we will have our annual Liver Expo on October 14th. So annual Liver Expo is something that we do every year, and it's a day-long program that allows patients to come and listen to the experts talking about liver health and colon health. It also provides patients with an ability to have a fiber scan, to be tested for hepatitis C, to interact with the personal trainers, to learn how to cook healthfully. So it's a super fun event. If you're interested, please sign up for it or talk to Summer. She will give you more details on how to do it. And that's it. Yeah. Thank you. Questions?
If you have questions, raise your hand. We'll bring the mic around so the online audience can hear you.
Hello. I have a quick question on the drugs like Ozempic and Wegovy, like you were saying. Are there any documented side effects as of right now? I know for the surgery you said deficiency of vitamins. So is there any like side effects for those drugs?
Absolutely. Unfortunately, none of the drugs is side effect free, right? So the way that Ozempic and Wegovy work, they kind of slow down your gut motility. So it's intended, right? But with the symptoms that the patient may have, they may feel full, which is a good thing, right? We're kind of after that. But sometimes in some patients, feeling full translates into feeling nauseated, translates into vomiting. So those are the side effects that some patients just are not able to tolerate. We are getting better and starting slowly and allowing the patient's bodies to adjust to it. But that's definitely one of the side effects that's been described. The other side effect that you may have seen online is something called an Ozempic face. I don't know if you guys have seen that. And basically what that means is when we lose fat very rapidly, our face appears older. And, when this is something that you have to contend with. I think it's a cosmetic effect, and I think this is probably something that's doable, but it is out there.
When people are taking antipsychotic meds or other meds, many doctors do not follow up, at least I don't think they do, on saying you need to have liver testing or you need to be checked. What are the side effects? I know this is a real generalization about certain meds and the effect that they have on the liver. And how should we be concerned about that as far as the testing?
That's a really great question. Thank you for asking this. So a lot of the times, or sometimes antipsychotic meds may cause patients to gain weight. So it's not necessarily the patients are overeating or not exercising, but it's the medication itself that causes the weight gain. And indirectly, those medications may promote patients to develop fatty liver. So this is, again, one of the kind of the newer updates for drug-induced liver injury. It's an indirect way that the drugs cause the liver injury, which manifests itself as fatty liver disease. So I would certainly want to encourage anybody who is on antipsychotic medications, to have their doctor check their liver test and potentially refer them for that FibroScan testing. It's easy, it's non-invasive, and it would give us a lot of information.
Not all the hospitals have the FibroScan.
Not all the hospitals have the FibroScans. That is absolutely true, but you're more than welcome to come and have it tested at our hospital. I think we had a question over here.
Okay, so I just wanted like more clarification on how exactly the scarring is reversed. Because if we think of like the epidermis, which is your skin, a lot of times that scarring never goes away. So like if it's only slightly progressed, is it when it reverses, or is it like an overall type of thing that happens?
That's a really good question. And certainly, if the scarring has progressed so far that the patient's liver is no longer functioning, and oftentimes when that happens, there's lots of things that we can see, like on a physical exam, patients turn yellow, patients' belly may be filled with fluid, they may be confused. So at that point, it's definitely irreversible, right? But if you are before that stage, even there's a decent amount of scarring present, treating your hepatitis C or getting you to lose weight and exercise, that is still very possible. And that for the longest time, we did not think that was the case, but now we have definitive proof that it's possible. Anybody else? Sure.
If anybody else has any questions, that'd be great. There's a question about, can non-alcoholic fatty liver disease be passed down from generation to generation? You sort of talked about that. Or does non-alcoholic fatty liver disease occur over time? Can it be just something you're born with? And if my dad has it, is there a chance that I'll have it?
Gotcha.
Or just something my lifestyle causes me to?
Got
get
it.
the
So I
disease?
think the answer is a little bit of both, or probably a lot of both. Like we talked about the genetic predisposition that certain ethnicities have. So yes, if my dad has it, I'm more likely to have it, but it doesn't mean that if my dad has it, I am definitely on the path to get there. So there's so much we can do, by leading healthy lifestyle and exercising and avoiding soda and junk food that can really overcome our genetic predisposition.
Sense. There's another question about thoughts on finding the systemic problem that's causing the metabolic disorder. Any thoughts about that?
I actually had a slide on that and I took it out. Basically, it's super complicated. There's just a whole bunch of different pathways and this and that and the third thing. There's lots and lots of research that goes on it, but we're just not there to put it into clinical practice. Are we good? Yeah.
So I know that the research focused on ethnicities, and I thought that was like really good clarification. But I was just wondering if you also focused on genders, if there was any variation between females and males, and if you are like just going to be progressively looking into that even after post maternity, post birth for females, or post aging in males, and all of that, and if that varies in your research.
Yeah, a lot of research goes on into the gender differences, absolutely. And we do know that women are at a potentially higher risk for fatty liver disease. And what we found out is over the last few years, fatty liver disease leading to cirrhosis in women is #1 reason for needing a transplant. So for men, it's still the alcohol. For women, it is fatty liver disease. So absolutely, there's a lot of gender differences, and there's a lot of research that goes on. Maybe there are different approaches, to men and women when it comes to metabolic health. Are we good? Great. Thank you so much. And then